well, I want to introduce our grand round speaker, Dr. David Fajgenbaum, who is joining us virtually from the University of Pennsylvania. Dr. Fajgenbaum is an assistant professor of medicine and is in the division of translational and genetic medicine at the University of Pennsylvania, a division that his interests are, kind of squarely appropriately aligned with. Dr. Fajgenbaum is going to share the story of how he became interested in a disease called Castleman's disease that results in a cytokine storm that can be so severe that it can be lethal. And now this all resonates with us on this Zoom because we now live this with our patients that have very severe COVID. And so one can easily see how studying a disease that you might not have heard of before getting on this call has implications for human health in broader ways. David is obviously highly intelligent and gifted, not only as a physician scientist, he's also an author. And David knows this, but maybe some of you don't know that anyone who submitted a poster has gotten a copy of his book. And we wish that he could have signed it in person, but he has signed all of these books for us. We have more, by the way, for those of you who are listening. We're happy to share some additional books that we have for you or for your trainees. And I think that Research Day isn't only about listening to other people's science, but my hope is that this will tickle some of you to want to do this for a living and see that you also can identify something you've seen in the clinic and try to figure this out and try to help the cause and try to help patients that you might not directly see, but that have these diseases. So David, I don't want to eat into any more of your time, and we're delighted to have you, and we wish you were here in person with us.
Maria, thank you so much for that warm introduction. It's been great to meet with you and a number of your colleagues this morning. Like I said, or like you said, I wish we were all in person today, but we'll do things virtually. So I'm going to begin by sharing my screen. Great. So I titled my talk "Personalized Medicine." And I think all of us are well aware of what is personalized medicine. I think sometimes it seems like that's all everyone talks about these days. But I'll be sharing a personal journey towards personalized medicine and the lessons that I learned in my journey chasing my cure. My really three goals today. The first is to share the perspective of a patient, physician, researcher, and advocate in the battle and the journey towards a rare disease treatment. In the process, I want to highlight some novel insights and therapeutic approaches for Castleman disease and related cytokine storm disorders like COVID. And finally, to discuss the potential for drug repurposing and how this is, in my opinion, a really important avenue towards identifying treatments for the thousands of diseases that don't have any treatments currently. Here are my disclosures. I received research funding from Janssen and UTSA for a registry, and I've received study drug from Pfizer for a clinical trial. I think the reason that I was asked to give Research Day, and I think the reason why I give a number of talks like this, is that I'm going to do my best today to share 5 different perspectives that for me, I think are critical to making progress on a scientific level and a clinical level. So the first is the perspective of a loved one of a patient. My mom was diagnosed with brain cancer shortly after I began my freshman year of college. And her diagnosis with brain cancer and then her passing about a year later motivated me to want to dedicate my life towards searching for treatment for patients like my mom. So if you fast forward a few years later, when I was a Penn Med student, training and hoping to one day become an oncologist so I could treat patients like my mom and be involved in translational research, I then turned into a patient where I was in the intensive care unit with multi-organ system failure, fighting for survival and unfortunately nearly dying multiple times before eventually receiving a rare disease diagnosis, and then learning that the only way that I was going to survive is if I got involved in searching for a treatment that could save my life. And then eventually learning that it was unlikely that I would make progress on my own. What I needed to do was to build a team and connect with other patients, physicians, and researchers to really make progress together. So it's these 5 perspectives that in this case, I happen to be the same person, but I think that it's important, an important lesson from my journey is that we need to bring together these perspectives across medicine. You don't have to be the patient, the doctor, the researcher, and the advocate, but you need to find a researcher, an advocate, and a patient to work with to make the progress that we have. So in a really simple way, I think about it as patient, physician, loved one, or advocate, researcher, and loved one, and not even just working together across those 5 perspectives, but engaging intimately with the FDA and also with pharmaceutical companies. On the panel that I was on earlier this morning, there were a lot of really important anecdotes about working with pharmaceutical companies to advance science and drug discovery for rare diseases. And I think it's critical that we in academia embrace all 7 of these perspectives and realize that not a single one of us can make the progress necessary on our own for our individual patients, but it's connecting these perspectives where we can make real progress for the patient in front of you across a given disease, and even between diseases. I think there's really important there's important opportunity for collaboration. So my talk today, I'm going to start out by sharing my personal journey. I'm going to highlight how we identified a novel therapeutic target that's saving my life, talk a bit about personalized medicine a bit more broadly, impact beyond Castleman disease and future directions. So I'll start out with a traditional case report about a 25-year-old male medical student who presents to the emergency department back in 2010. I'm going to let you guess who this medical student was. But he presented with 3 weeks of fatigue, weight loss, and what were described as blood moles that had been appearing all over his body. And about 5 days worth of flu-like symptoms, abdominal pain, but no significant past medical history. The physical exam was notable for palpable lymphadenopathy and some edema around the ankles. And this is a totally previously healthy individual. Hemoglobin was normal to borderline, maybe low for a healthy person. Platelets were basically normal, lower end of normal. The elevated creatinine was notable for this patient, and the patient felt really, really badly. A CT scan was done because of lymphadenopathy, which revealed disseminated lymphadenopathy, hepatosplenomegaly, fluid in the lungs, and fluid in the abdomen. So I imagine many of you are thinking through what's your differential. Of course, it was a broad differential. This could be an aggressive lymphoma, could be an acute infectious disease like mono, could be an atypical presentation of an autoimmune condition. It could be some kind of combination of this like HLH. But we, of course, didn't know what the diagnosis was. Patient was almost immediately transferred to the intensive care unit due to multi-organ failure, gained 70 pounds of fluid with an albumin level around 1, significant renal dysfunction requiring dialysis 3 times a week, a CRP over 300, lots of inflammation and acute retinal hemorrhage causing temporary blindness, elevated LFTs, which led the team to consult Dave Goldberg, who's on the call right now, and get him involved in the process. Also notable for pretty severe anemia requiring RBCs every other day, and notable thrombocytopenia requiring platelets daily transfusion of platelets to keep that number above 10,000. So I'm sure you can imagine that we called in a lot of services. So Room came in and they found some notable positives, a low positive ANA, a few other autoantibodies, but notably no joint pain, no specific autoantibodies, and no response to corticosteroids. The infectious disease team came in and found evidence of a historic EBV infection, but no sort of acute infection was discovered. And lastly, Hem-Onc came in, and it was notable for this tumor lysis-like syndrome when high-dose steroids were given, but other than that, everything else was pretty negative. So a reactive bone marrow, a relatively normal interleukin-6 level, normal immunoglobulin levels. So really nothing standing out at this stage. So with no diagnosis, the patient continued to get worse and worse. And just because I'm going to have a hard time remembering to say patient, I'll go ahead and tell you that I'm the patient. And in the midst of this this challenging time while I was in the intensive care unit, my dad got a phone number for a physician at the NIH. Basically, a family friend was like, look, you don't know the diagnosis, but like you should call this guy. You know, he's familiar with these sort of inflammatory disorders. And my dad didn't know who he was, but he started calling this doctor every day. And every day he would tell this NIH doctor all of my lab tests and my clinical features and what was going on. And every day this doctor would spend like 30 to 45 minutes on the phone with my dad, talking through what the differential could be and what to do next. And about 6 months later, when I eventually was discharged from the hospital, I asked my dad, I said, Dad, who was that doctor that you were calling every day? And my dad's from Trinidad, and he in Trinidad in the Caribbean, and he's got a really strong accent, and he never pronounces any names right. And he said, oh, you mean Fucci? I don't know who he is. Just Google NIH Fucci. I don't know who he was. So I Googled Fucci NIH, and I learned that my dad had been talking to Dr. Tony Fauci every day for those weeks, and my dad had no idea who he was. And by that stage, of course, everyone knows who he is now, but at that stage, he had already won a Presidential Medal of Freedom. So my dad most certainly should have known who Dr. Fauci was. But anyway, it's been pretty funny to connect with Dr. Fauci since then and laugh about how your dad kept calling me Fucci, and I don't think he knew who I was. But of course, I think the reason I share this story is really because I think it highlights what goes on behind the scenes for a lot of your patients, and that's that your patients' loved ones will do anything and everything to get towards a diagnosis, do anything they can. And so, I mentioned my role as a loved one being important as part of this sort of ecosystem toward cures. And I think it's important to not forget the family members who are very much a part of your patient's journey. Thankfully, in the midst of all of these discussions, and as I continue to get more and more sick, a lymph node biopsy was eventually performed. This is a picture of my lymph node, zoomed in pretty far. I'm sure many of you don't look at lymph nodes, but the point here to highlight are two. One is that my lymph node was highly vascularized. It was considered to be one of the most vascularized lymph nodes that really any pathologist had seen outside the setting of lymphoma. And then secondly, there were these atypical germinal centers. You probably don't remember germinal centers from medical school, but atypical in shape and in size. And in the setting of high vascularity and these atypical germinal centers, the pathologists said they thought this was idiopathic multicentric Castleman disease. So IMCD is a rare inflammatory disorder that was first described back in the 50s by Benjamin Castleman. So the disease is named after Dr. Castleman. He described these, atypical looking lymph nodes in the setting of inflammation. And it's typically, you think someone has lymphoma, you cut out the lymph node, and then a pathologist says it's not lymphoma, it's Castleman disease. Castleman disease really described a group of disorders. So there's unicentric Castleman disease, where there's a single solitary enlarged lymph node, and the patients typically have very mild symptoms. You cut out the lymph node and the patients are generally cured. But then there are two forms of multicentric Castleman disease. So there are actually multiple forms of multicentric Castleman disease. Multicentric meaning multiple regions of enlarged lymph nodes. So I had multicentric Castleman disease, I had disseminated lymphadenopathy. That can be caused by infection with human herpes virus 8. HHV8 actually, in normal individuals who don't have a compromised immune system, will cause no symptoms. So about 10% of the US population is infected with HHV8, and nearly all of them have no symptoms. But if you're infected with HHV8 and you have some sort of reason that you're immunocompromised, let's say with HIV or an organ transplant, then you can develop HHV8-associated MCD, which is the cytokine storm that occurs because your immune system can't control the virus. The virus spirals out of control, and you get really, really sick with a cytokine storm. Fortunately, B-cell depletion with rituximab is actually very effective for HHV8-associated MCD. Then there's another form of multicentric Castleman disease that occurs in the context of a form of cancer, a malignancy called POEM syndrome. So there's a monoclonal plasma cell population where it's that cancerous cell population that's producing cytokines that ignites the cytokine storm. And so you get a lot of cytokines, you get really, really sick, and you get MCD. But then there's a third form of multicentric Castleman disease where you get a cytokine storm, just like you get with a virus or just like you get with POEM syndrome, but we don't know what causes it. We call it idiopathic multicentric Castleman disease because we don't know the cause. And so idiopathic MCD is the form of MCD that I have. Now, back when I was diagnosed and I presented, there was no diagnostic criteria for IMCD. So we developed that, we published it a few years ago, but there was at least kind of an idea for how do you diagnose it, but of course no criteria. So you need multiple regions of enlarged lymph nodes. You need lymph nodes that demonstrate this Castleman's-like histopathology, and you need at least 2 of the 11 minor criteria to be present. And you'll see that these are actually quite non-specific minor criteria: fluid accumulation, inflammation, organ dysfunction, that certainly can be seen in other conditions. And so it's important, finally, to rule out conditions that can demonstrate similar clinical and laboratory manifestations and also histopathological changes. A little bit more about IMCD. About 1/3 of patients will die within 5 years of diagnosis, and another 1/3 will die within about 10 years of diagnosis. It can affect individuals of all ages. Our youngest patient in our community was 1 year old when she was diagnosed. You know, we have patients who get diagnosed all the way into their 60s or 70s. So it really broadly affects the population. IMCD is interesting because it really does sit at the intersection of autoimmunity, infectious disease, and malignancy. And there's features of IMCD that you can see in a number of conditions. And as was mentioned at the very beginning, a number of conditions such as COVID. So for years, from the time that Benjamin Castleman first described Castleman disease, it was clear what the clinical pathological picture of the disease looked like. Flu-like symptoms, organ dysfunction, these abnormal lymph nodes, that was well established. But what wasn't clear was what caused this sort of clinical picture. And back in 1989, Kazuo Yoshizaki discovered that interleukin-6 was elevated in just a few patients. It was actually a study of just 3 patients that was published in Blood. He found that interleukin-6 was elevated, and he thought, because he also was part of discovering the biology of interleukin-6, he thought that it might also be causative, or at least a disease driver in IMCD patients. But even back then, and even still to this day, there's been a bit of a black box around, well, why is the interleukin-6 elevated in the first place? What signaling pathways, what cell types, and what causes exist for why the interleukin-6 is elevated? But importantly, Kazuo said, well, who cares why the interleukin-6 is elevated? Why don't I just block its signaling and maybe that'll be effective? And so he developed a drug called tocilizumab, or Actemra, that blocks the receptor for interleukin-6. And more recently, there was a new generation of IL-6 blocker, siltuximab, which blocks interleukin-6 directly. And thankfully, about 1/3 of patients just get better when you block IL-6. We may not know why, but if you block IL-6, you just get better. And that is incredible. These patients go from being on a ventilator in the ICU to like walking out of the ICU a few days later and being discharged a few weeks later. It's pretty incredible. Unfortunately, for 2/3 of us, which I fall into this category, you can block interleukin-6 with all the IL-6 blockade you want, and we don't get better. And so what's challenging for a patient like me is that the only thing known about IMCD was that IL-6 was the problem. And then the only drug in development was an IL-6 blocker. And then when you fail to respond to that IL-6 blocker, you end up in a scenario like this, where question mark leads to question mark leads to question mark, which is a hard thing to treat when that's the established knowledge for the disease. So the way you do treat question mark leads to question mark leads to question mark is with cytotoxic chemotherapy, because we may not know what cell types are involved or what signaling pathways are involved. But we know that they're immune cells, and we know that if we just ablate the entire immune system, that we'll knock out the problem cells. And so that's what we do for patients who don't benefit from IL-6 blockade. I wanted to share a quick anecdote about my friend Kazuo Yoshizaki. So this is Kazuo and I a few years ago at a meeting. I mentioned Kazuo made the discovery that interleukin-6 was elevated, and then he also went on to develop a drug that blocks the receptor for interleukin-6 called Actemra or tocilizumab. What I learned a few years ago from a colleague of ours, Makoto, was that Kazuo tested the drug on himself to prove that it was safe. And at one of our meetings, I went to Kazuo, I said, Kazuo, Makoto just told me that you gave tocilizumab to yourself as the first human to prove that it was safe back in the 90s. And he said, no, I didn't give it to myself. The nurse, she gave it to me. So Kazuo Yoshizaki discovered interleukin-6 was the problem. He developed a drug to target interleukin-6. He tested it on himself to prove that it didn't kill him, because this is back in the 90s when monoclonal antibodies were a new technology. And then he went on to test it in Castleman disease patients. It got approval in Japan for Castleman disease. That was the initial indication, the initial purpose of Actemra, which for Castleman disease in Japan. Got approval in Japan. Years later, it went on to get approval here in the United States for rheumatoid arthritis. And as many of you all probably have also followed, tocilizumab has been used in a number of other conditions as well. So here in Philadelphia, where everyone thinks about is cellular immunotherapy, tocilizumab really was a lifesaver and a game changer, because the very first pediatric patient photographed here, Emily Whitehead, who ever got CAR therapy, the first pediatric patient, she was in the ICU at CHOP with a cytokine storm that looked just like Castleman disease. And our colleague Carl June and his team decided to try tocilizumab to treat this patient who was experiencing a cytokine storm from her CAR therapy, and it saved her life. It thankfully saved Emily Whitehead's life. It also, in my opinion, likely saved the entire CAR-19 research program, because if the first pediatric patient had died, I can only imagine the whole program would have been tanked. And of course, now CAR therapy is it's obviously an exciting area in medicine. Interestingly, back when the COVID pandemic emerged, many folks in China, but also in other parts of the country, began using tocilizumab in the most severe cases. There were a lot of anecdotal reports that were really promising. There was even an early RCT that was promising, and then there were a number of RCTs that were considered to be negative. But more recently, as a number of large randomized controlled trials have read out, it's become clear from now thousands and thousands of patients that tocilizumab has a really important role in a narrow window of patients that are progressing towards the ICU or are recently admitted to the ICU. You can actually improve mortality in those patients. And so this is a drug developed for Castleman disease by a Castleman's doctor in Japan decades ago. It has saved countless lives from CAR therapy patients. It's saved countless lives from COVID patients, and certainly helped a number of rheumatoid arthritis patients around the world, which I think is an important lesson for all of us. So I got IL-6 blockade. I was on that. I was given that drug siltuximab as part of emergency compassionate use because the drug wasn't approved yet, and it didn't work for me. I continued to get more and more sick. So I ended up getting multi-agent chemotherapy, a combination of adriamycin, Cytoxan, etoposide, Velcade, dexmedetomidine, Rituxan, a 7-agent combo that worked really, really well. You can see here I'm sitting up next to my dad. This is months into my illness, and I'm finally sitting up, doing well. You can see I still got a big belly because I was still getting dialysis 3 times a week because my kidneys weren't working. I was getting my belly tapped 4 to 5 times a week and getting 5 to 7 liters of fluid taken out each time. So I had this huge belly from the ascites. And I show this picture because there's a funny anecdote that I want to highlight, and that's that the photograph on the right side of the screen was taken at about 8 p.m. on New Year's Eve 2010. And my dad and I went for a walk around the hematology oncology unit. And as we passed the family waiting room, we saw that there was a gentleman who had clearly been drinking on New Year's Eve. He was like visibly drunk. He was kind of swaying in his chair. And on our next lap around the unit, we saw that this guy had fallen onto the ground. And so my dad ran over to this drunk gentleman and put him back into his chair. And he looked at my dad and I, and he said, "Thanks so much. Good luck to you and your wife." And we were thinking, wife, what is he talking about? And then I looked at my belly and I realized that he thought that I was my dad's 9-month pregnant wife, and that we were walking laps to prepare to deliver our child, which certainly could have been a low point emotionally for both of us. But we just burst into laughter. And I think that I highlight this because many of you that deal with really sick patients in really tough times will probably appreciate that laughter and humor is actually sometimes the only thing that can get us through really, really tough times. So I was discharged from the hospital about 7 weeks later, thanks to this multi-agent chemotherapy. And you can see my head was bald from the chemo. You can see maybe how someone might have confused me as my father's pregnant wife. And this picture is from a few years before when I played college football at Georgetown. I always say this is like the worst before and after picture of all time. But if you could flip the order, it would be this great advertisement for Peloton or for Muscle Milk. But unfortunately, these pictures are in the wrong order. And I feel totally okay sharing the picture on the left because it's not bragging, because I've fully embraced that I have a dad bod these days that fits somewhere in between these two photos. took a picture every week for the next 8 weeks, and you can see my hair starting to grow back. You can see my belly starting to go away, and I look less pregnant by the end of the 8 weeks. So I got out of the hospital, and shortly after getting out of the hospital, and I actually was continued on that experimental drug siltuximab. Even though it didn't work in the acute setting, we hoped that maybe it could help to prevent a relapse. So I was on this experimental drug, and I eventually returned back to Penn for medical school. I was on medical leave for about a year. And right when I got back to Penn, I learned that a major donation had been given to Penn to start an orphan disease center, and that our dean, who had just retired, Arthur Rubenstein, was named the interim director of the Orphan Disease Center. And so I reached out to Arthur and I said, Arthur, I have an orphan disease. I'm on an orphan drug. I didn't share it as part of this talk, but I had experience starting a nonprofit years before for grieving college students, and I would love to be a part of growing the center with you. And he very graciously allowed me to be a part of the early strategic planning for the Orphan Disease Center, and also the selection of the first full-time director of ODC. And over the course of my work through the Orphan Disease Center, it just became clear the hurdles and the challenges in the rare disease space. This was back in 2012 when there were even less folks interested in orphan disease than there are today. But I really loved my time working in the Orphan Disease Center. I was very focused on rare diseases generally, and much less interested in Castleman disease, because I figured I was on an experimental drug. It's, hopefully going to keep me in remission. I can just keep on my path of doing what I was doing. And then I relapsed. And so I relapsed and nearly died for the 4th time. And what was so tough about this relapse was that experimental drug that didn't work when I was acutely ill, now it also didn't work to prevent a relapse. And so I was fully out of options. And I had a conversation with my doctor, who explained to me that there were no more drugs in development. There were no more promising leads, and there was nothing else that anyone had ever even conceptualized other than interleukin-6 to target for Castleman disease. And that really, it was just, for me, it was just going to be repeated relapses, and we were going to hope that chemotherapy would work with every relapse. But we were realistic, knowing that if you play Russian roulette enough times, that one of these relapses is going to be deadly. And so when my doctor left the room, I turned to my dad, my sisters, and my girlfriend at the time, and I told them, I said, I'm going to dedicate the rest of my life, however long that may be, to trying to find a treatment that could maybe save my life and other patients like me, other IL-6 refractory patients. So there was no one at Penn studying Castleman disease, but a colleague of mine in the pulmonology division gave me some space in her lab, and I set up a protocol so I could start performing experiments on my own samples. I couldn't get my hands on many other samples, but I certainly could get my hands on my own samples. But I also wasn't unrealistic in realizing that I was unlikely to make progress on my own. The best chance I had to make progress was to start a foundation called the Castleman Disease Collaborative Network, to bring together physicians, researchers, and patients from around the world to work together to advance the science for Castleman disease. And during the workshop earlier today, I was able to share a bit more about the approach that we've taken, what we call the collaborative network approach. I don't have time this afternoon to share with you all about the collaborative network approach, but certainly, would be thrilled for you to learn more about it online. You can certainly email me the way that we do research. So I shared the realization that I would need to spend the rest of my life studying this disease, that I needed to find a drug. But for me, there was a bigger, it wasn't just this specific realization, it was more like a bigger epiphany. And that was that I went from being a very hopeful person who had hoped that some researcher somewhere would figure out something for me, to realizing something very different. And I'm going to read a passage from my book. So I learned that hope cannot be a passive concept. It's a choice and a force. Hoping for something takes more than casting out a wish to the universe and waiting for it to occur. Hope should inspire action. And when it does inspire action in medicine and science, that hope can become a reality beyond your wildest dreams. And so it was a major turning point when I went from being hopeful to being someone that hopes. I reflect on what I'm hoping for, and then I try to figure out what action can I take today to get closer to that which I'm hoping for. The next thing was to get a sense for, well, what's being done and what has been done for Castleman disease. At the time, there was about $10,000 a year that had been invested into Castleman's research. So basically nothing. The NIH had never given a grant for IMCD research. There were no patients in a registry because no registry existed. There were 2 organizations that existed, but there was no research infrastructure or plan. There were no cell lines, animal models, biobanks. The disease was poorly understood. There was no diagnostic criteria, no treatment guidelines, no biomarkers that could predict whether one drug would work better than another drug, no FDA-approved therapies, and there was only one drug in development, but the one drug in development, zoltuximab, didn't work for me. So it was pretty frightening to get out of the hospital and to get a sense for like what the field was back in 2012. One of the first things I did was to hold a webinar with other Castleman disease patients. I wanted to get a sense for what research questions would be important to them, what they were hopeful we could do through the Castleman Disease Collaborative Network. And I held a webinar and I showed this picture of a Castleman. So we kind of repurposed the idea of Castleman disease. So Benjamin Castleman, of course, is what the disease is named after, but we created a Castleman, which I have in my jacket, and you can see on the screen as representing a warrior, and showed it to a bunch of patients, and they thought it was great. And a couple of weeks later, we saw on our Facebook page that one of our patients had screenshotted the image and then got it tattooed on his shoulder. And I always say, if this isn't patient engagement, then I don't know what patient engagement is. But our community, that now there are hundreds, maybe even thousands of Castleman tattoos on patients all over the world. The patient community was just waiting for something to get behind. The next thing I needed to do was to build a team. So I was a medical student when I first started the CDCN, and then I went on to go to business school, also at Penn. And in between both of those schools, I recruited classmates of mine to be a part of the Castleman Disease Collaborative Network, to be a part of identifying the right research studies, getting resources together to fund them, facilitating collaboration between researchers. And you can see in many of these pictures, we're doing what we call the Castleman Flex. So kind of in line with this idea of we're warriors, we do this Castleman Flex. Which if we were all together in Miami, I would beg all of you to stand up in your chairs and to do this Castleman Flex for a photograph. But I guess the best I can do is beg that maybe you all will take a picture in your home office doing a Castleman Flex and post it on social media to raise some awareness about Castleman disease. Once we had the patient community on board, once we had a team of volunteers, the next step was to turn to the physician researcher community and to get a sense for everyone worldwide that had either treated a Castleman's patient, was doing Castleman's research, or was doing research on a related inflammatory condition. And we spent a lot of time connecting these folks. And thankfully now we have a huge network of physicians and researchers worldwide who contribute research ideas toward what we should do. And then we go out and we recruit the best researchers in the world to actually perform those studies. The formula that we've followed for the CDCN, which I think is certainly replicable for other groups, is to begin by really trying to dissect the biology of Castleman disease. And the way we do that is first by investing lots of time and effort into getting really high quality biospecimens from patients. So patients hospitalized in Miami or Seattle or wherever they may be with idiopathic multicentric Castleman disease, we can consent them by telephone. We can consent their family members if they're incapacitated, and we can send empty tubes by mail to the family. And then the clinicians will draw tubes along with a normal clinical blood draw, send those tubes back to us so we can get high quality biospecimens from patients in the midst of active disease. We also have a natural history registry where once the patient enrolls, we get their complete medical records, and then we manually extract data from their medical records into our database. So we get between 3,000 and 4,000 data points per patient. So really high quality biospecimens with really in-depth clinical phenotype data with each of those biospecimens. Then we're in a position to really leverage the data and the samples for what we call our international research agenda, which is a mix of translational research and omic studies that are really discovery-based, and then really hypothesis-driven studies as well. What we learned from understanding Castleman disease biology, we then translate that towards modulating therapeutic targets that we've identified. We always start out with drugs that are already FDA approved. So we say, okay, well, maybe JAK1/2 inhibition looks to be promising for Castleman disease, or maybe blocking IL-1 looks promising. We publish it, and then because of the major unmet medical need, a lot of doctors will just use these drugs off-label. They'll just try them out and see, does the patient get better when we actually block that thing? Thankfully, we have Accelerate, that registry in place, so we can get data on if it worked or if it doesn't work. So there's some real-time discovery, utilization, and tracking of whether drugs look promising or not. The most promising drugs we move forward to our clinical trials. We've got one trial open, a trial called RAPID, which I'll share a bit more about the drug a bit later. And then we also use data on what drugs work, what drugs don't work, and all of our omic data to try to identify predictive biomarkers so we can actually predict who's likely to benefit from one drug or another. And then we feed all this information back into our understanding of biology, because if IL-6 blockade works, then you know that in those patients, interleukin-6 was the driver of disease pathogenesis. If it doesn't work, then interleukin-6 wasn't, and let's go back to the drawing board and figure out what is driving disease pathogenesis. So this sort of cycle or storm has been really critical for us. I would love to actually go through every study that's underway, but you can go to cbcn.org/research and get a sense for all the studies currently underway. For Castleman disease, there was one study underway when we got started back in 2012, and now there are well over 30 going on around the world. So you're going to transition now into identifying a novel therapeutic target. In between all of this progress, I graduated from medical school and began business school. This is a picture of me and my girlfriend, Caitlin, at the time. Right around the time these photographs were taken, we got engaged to get married. But as you'll see in the photograph on the right, I'm bald again, and that's because I relapsed and nearly died for the 5th time. And this time I relapsed and nearly died while on weekly chemotherapy. So even the chemo wasn't preventing a relapse. And I knew that if I wanted to survive, that I would need to find a drug that we could repurpose. I'm going to fly through this pretty quickly. You can actually take a look at the citation at the bottom of the screen to get more details on the journey. But basically, what I'm highlighting here is that over the course of a 3.5-year period, a lot of different drugs were tried. There were a lot of peaks and valleys. The vertical dotted lines represent admissions to the hospital, where I spent almost 6 months hospitalized to start out. You can see the different drugs that were tried. The drugs that eventually gave me an extended remission were Velcade, thalidomide, adriamycin, cytoxan, and etoposide. That combination gave me a year-long remission, and then again gave me another year-long remission. But I relapsed while on maintenance therapy with Velcade, thalidomide, and I really was out of options. And so what do you do when you fail to respond to every drug that's ever been reported to be used for Castleman disease? Well, you have to find a novel approach. And what we did was go through, we've been running cytokine panels, measuring 13 cytokines every few weeks leading up to my 5th relapse. And what we found was that during my relapse, almost all of the cytokines we were measuring were elevated. But importantly, we found that 2 cytokines began to rise in the weeks and the months leading up to relapse. So one of them was vascular endothelial growth factor, of course, critical for blood vessel development. The other is soluble IL-2 receptor, which is a marker of T cell activation. So this sort of kinetic change in these 2 proteins suggested to us that maybe VEGF and maybe T cell activation were important in actually leading up to the cytokine storm, where basically everything's out of control by the time you get to the cytokine storm. I had stored some serum samples and PBMCs on myself during that relapse. I also requested that a lymph node get resected for me when I relapsed, because I knew that if I survived, I wanted to have some tissue to work on. And so was able to go to those samples and confirm that in fact my T cells were highly activated, and that VEGF was one of the most elevated proteins, even when we measured over 1,000 proteins. I mentioned at the beginning of the talk that blood vessel growth and hypervascularization was part of what led to the diagnosis of Castleman disease. So for years, we've known that Castleman's lymph nodes are highly vascularized. And so the idea that VEGF would be important and elevated is certainly consistent with the clinical phenotype. I mentioned the cherry hemangiomas at the very beginning of my talk. No one paid attention to my cherry hemangiomas. I kept saying to my ICU doctors, what about the blood moles? And they were like, your liver, your kidneys, and your bone marrow have shut down. Forget about the blood moles. They don't mean anything. But certainly, the cherry hemangiomas would be consistent with having elevated systemic VEGF levels. And then the incredible fluid accumulation that I had would again be consistent with an important role for VEGF. the question became, is there some sort of final common pathway that's involved in the cytokine production we see, the T cell activation we see, and the excess VEGF levels? And just to kind of piece this together, we pulled those data together and used a series of pathway analyses tools to ask the question, are there any signaling pathways that, that could potentially explain the various proteomic changes that we see? And actually, what we found repeatedly, regardless of what pathway analysis tools we used, were that the PI3 kinase AKT mTOR signaling pathway was identified as an enriched pathway, and that maybe this pathway, the mTOR pathway, could be important in my disease process. And you can imagine that we would want to validate that because this was just a hypothesis. But we did, and I should mention also, mTOR is critical for T cell activation, VEGF production, and also immune hyperactivation. So it certainly fit the bill that mTOR might be a central node in this, in pathogenesis. And so we did a really simple experiment. We did immunohistochemistry for phospho-S6. The S6 is a marker of mTOR activation. And I first did it on a bunch of normal lymph nodes. And you can see in a normal lymph node, there are some cells that stain positive for mTOR activation. There's certainly some mTOR activation in a normal lymph node. And then when I stained my lymph node, this is what it looked like. And I was just immediately blown away by the incredible amount of mTOR activation present in my lymph node. And at this stage, this didn't guarantee that blocking mTOR would be effective, but it did suggest that there was increased mTOR activation, that maybe if we blocked mTOR, maybe it could be effective for treating my condition. And so I was started on an mTOR inhibitor a little bit over 7 years ago, and you can see by the bar graph here, it's been 86.16 months since my last relapse. And I say that because I know that I can't round up. I don't know if I'm going to make it to 87 months in remission on this treatment, but I also don't round down. I'm so thankful for every fraction of a month, of a week, of a day even, of remission that I have and that other patients also have. The New York Times called this "Doctor Cure Thyself," which I think is a bit of an overstatement. I think it probably more appropriately should have been doctor helping himself a little bit right now and hopefully for a little bit longer. But I don't think that would have fit on the headline. Importantly, Caitlin and I made it to our wedding day. This is a picture of Caitlin and I on May 24th, 2014. My hair grew back just in time for the wedding, which actually was somewhat important to me. I didn't want to have the external appearance and the reminder of all that I had gone through and all that I likely would continue to put Caitlin through. A couple of years ago, Caitlin and I had a daughter, Amelia. This is her around her first birthday. And then this is us on the most recent Halloween. Amelia is dressed as Amelia Earhart in this picture, and Caitlin and I are her aviation crew, which I mentioned last night during the call with Books and Books. I think this is a perfect symbol for how things are in our house. Amelia is the pilot, she is the boss, and Caitlin and I just kind of try to redirect her and keep her moving in the right direction. During this remission, I joined the faculty at Penn, where I launched a center called the Center for Cytokine Storm Treatment and Laboratory, or the CASTLE, as we like to call ourselves. When we started the CASTLE, the intention was to focus on Castleman disease and cytokine storm disorders like Castleman disease, such as what you see with cellular immunotherapy, like CAR therapy. And then I think the whole world was surprised a year ago when it became clear that obviously COVID would be this terrible pandemic, but that the most severe patients with COVID would experience a cytokine storm. And so we've pivoted a lot of our attention towards COVID. I've got a slide later on. I'm actually gonna have to skip over it just due to time, but you can go to cdcn.org/corona and you'll be able to follow the work we've been doing. We run the world's largest database of treatments that have been identified to either be promising or effective in the treatment of COVID. There have been over 400 different drugs that have been tried to treat COVID patients. And you've probably heard about a lot of them that haven't worked at all, but there are a few that have worked really, really well. I'm sure many of you are wondering, well, what about other patients? What's happening with mTOR and other patients? Well, we published in JCI a couple of years ago the discovery of mTOR as a therapeutic target and the utilization of sirolimus in the first 3 patients. Last year, we published work expanding from 3 patients to 26 Castleman's patients. And then we also published on a potential candidate driver that could explain the increased mTOR activation, and that's a hypersensitivity to type 1 interferon that we think could potentially be underlying pathogenesis. As a result of our findings, we've begun to give sirolimus to other patients. This is a young patient, Joey, who was very sick in the Children's Hospital of Philadelphia ICU, didn't respond to first or second line therapy, but had a really positive response to sirolimus. And then two more patients, Lisa and Sergio, who also didn't respond to first or second line therapy, but unfortunately, despite chemotherapy, despite mTOR inhibition, also did not survive. And so unfortunately, it's patients like Lisa and Sergio that really motivate us to continue to push our science forward, because we've made progress, but we still have a long ways to go. I'm actually going to skip this next section of my slides. I think I was overly ambitious with all of the things that I would be able to cover. But the bottom line is that we recently uncovered a new therapeutic target in Castleman disease, and that's hitting JAK1 or JAK2 with a drug like ruxolitinib. And what you'll notice when you look at a chart like this, this is kind of our new model of how we think about Castleman, is that we're always focused on existing drugs that are already FDA approved. Sirolimus had been around for 30 years, or had been around for 20 years when I first started taking it. It's now been over 30 years. And so these are old drugs with well-established safety profiles, clear understanding for biology. And so everything we do, it's about what's going on biologically, what existing drug might be able to have an effect on the disease without having to develop new drugs from scratch. So I'm going to show on the screen here in white where we were back in 2012, and now I'm going to superimpose where we are today. So over the last 9 years almost, we've raised $1.5 million for research, spent that $1.5 million very wisely on research studies, which has led to an additional $10.1 million in external funding from outside organizations. The NIH gave my lab the first IMCD grant a couple years ago. We have a registry with over 1,200 patients. There were two organizations before the CDCN. Now the three of us have combined together into one unified network. We've got a biobank. We're making progress towards understanding the disease. I mentioned we published diagnostic criteria a few years ago. We published treatment guidelines a couple years ago. We published the first ever predictive biomarkers of response to IL-6 blockade. We got another paper under review. That one drug, siltuximab, got approval. It's now approved for Castleman's, and there are two more drugs in development. The drug I'm on, sirolimus, which we have an open clinical trial of, and then we're really interested in developing JAK1/2 inhibitors for patients as well. So I really don't have time to talk about the relationship to COVID, but I will just quickly flip through and highlight that the patient on the left side of the screen is an IMCD patient on a ventilator in the ICU, and the patient on the right is a COVID patient on a ventilator in the ICU. And if you look in at their immune cells in their peripheral blood, they're almost indistinguishable. So the immune activation that we see in a COVID patient is in a severe COVID patient. It's very similar to what we see in an IMCD patient. Of course, the difference is that there's no virus that we've been able to find in IMCD. There's been a lot of discussion about, is cytokine storm the right term to use for COVID? And I think rightfully so. I think we all agree that the vast majority of COVID patients do not experience a cytokine storm. However, there certainly are very severe patients who do experience a cytokine storm, but it's hard to say that someone has a cytokine storm or not unless there's a definition for what is a cytokine storm disorder. So Carl June and I published a paper in the New England Journal a couple months ago, really defining for the first time what is a cytokine storm. And then you can have a debate on, okay, well, based on that definition, is this a cytokine storm disorder or not? And we feel quite strongly that the most severe COVID patients do have a cytokine storm because if you suppress their immune response with a corticosteroid or a JAK inhibitor, you can improve outcomes in the most severe cases, suggesting there's hyperinflammation or excessive cytokine production. So in the course of COVID, we decided that we wanted to get very involved in tracking all the drugs used for COVID and helping to identify new therapeutic approaches, which we do through that project, the Corona project, which I'm going to click through here really quickly. But I really do encourage you to go to cdcn.org/corona, and you'll be able to access all the data from around the world on drugs being tried for COVID-19. And we're working really closely. I sit on a working group for the NIH and also one for the FDA, where we're prioritizing the most high potential drugs for COVID clinical trials. And really the key for COVID is finding that right balance. You don't want too weak of an immune response, and you don't want too strong of an immune response. The virus is actually quite good at causing both too weak of a response and also too strong of a response. And that's really where therapeutics come in to get us towards that appropriately modulated immune response to COVID. So this is my last slide, and we'll still have a few minutes left for questions. I wanted to close with a handful of lessons from my journey chasing my cure. Of course, don't have the time to get into all the lessons from my journey, and was thrilled to hear that so many of you were getting copies of Chasing My Cure from the department. But I wanted to highlight a handful. The first is that hope can have many different forms. There's the kind of hope that helps you to keep fighting in the midst of tough times, which I certainly leaned on during my journey. But there's also the kind of hope that inspires you to take action, that says, okay, if I'm going to hope for something, if I'm going to pray for something, if I'm going to wish for something, what am I going to do today, tomorrow, and the next day to get closer to that which I'm hoping for? The second is for really everyone watching. I hope that none of you are ever confused as your father's pregnant wife. But if you are confused as your father's pregnant wife, I hope you can find some humor in that and in all of life's challenges. I think that during really tough times, laughing with the people you love is so, so important. The third is that communicating our limits is so important. If my doctor hadn't explained to me that I was out of options, that there were no promising leads, there was no cavalry on the way, I would have never gotten involved in research the way that I have. I think it's important that we're transparent and authentic with our patients about our limits. The fourth is that solutions may be hiding in plain sight. The drug I'm on has been around for decades, and no one had ever thought to try it for Castleman disease. How many more drugs are just sitting out there waiting to be tried? This is a visual that I wanted to highlight to show that there are about 2,500 drugs that are approved by the FDA, and they're approved for about 3,000 different diseases. But there are another 7,000 or so diseases that don't have anything approved for them. And many of the drugs that are currently approved for at least one condition could potentially be effective for other conditions. And right now I'm working with an FDA group and also the Chan-Zuckerberg Initiative to make this process of repurposing drugs more seamless and happen more frequently. And the last lesson is that my book's called Chasing My Cure, but it really should have been called Chasing Our Cures, because it really has been a team effort. It really does take an army to make progress like this. I hope all of you will be a part of this Chasing My Cure army. I hope that you'll help to raise awareness about the work we're doing for Castleman, cytokine storms, COVID. Take a look at Chasing My Cure and help to raise awareness about it and our lessons. So thank you all so much. I've only left a few minutes for questions, but would love it.
David, that was absolutely fantastic. Thank you. I learned now that we applaud by doing this on Zoom. So so everybody can see you clapping. Anyway, that was, truly, I would say inspirational, but that's a term that's used a lot with you. Your altruistic approach to helping people, it reminds me of the quote, I know what I have and I have what I know, really is, it shows us how much one can overcome, and when really truly motivated, can apply science in the most objective way to work for the betterment of society and the betterment of humankind. So thank you so much. Dr. Lakakis has a question from the audience. Laz, do you want to unmute yourself and ask your question?
Yeah, so your disease resembles two things to me: the vascularization on the lymph nodes and angioimmunoblastic T-cell lymphoma. So the one question is, what is the role of TFH, which is the cells that are neoplastic in this disease, in the angioimmunoblastic? The other one, with all of those peaks and valleys, the periodic fever syndromes, and what is the role of colchicine in the treatment, if there is any, of idiopathic multicentric calcium?
Great questions. Well, yes, so AITL is definitely on the differential for all of our Castleman's patients. In fact, people get misdiagnosed with both. So it looks histologically like AITL. There is just no monoclonal T-cell population like you see in AITL. Unfortunately, we haven't done enough work to characterize the TFH cells. I can tell you that in circulation that there's equivalent numbers of circulating TFH cells. I can tell you that they do appear to be a little more activated in circulation, but the work hasn't been done in lymph node tissue to really characterize actual TFH cells as opposed to these circulating TFH cells. But I think that's an exciting area to look into. I have to say that in the TFH kind of FDC dynamic that occurs in the germinal center. The FDCs appear to be more abnormal or more abnormal appearing. They have like a morphological change that makes us think that follicular dendritic cells may be the problem here. But I think it's a really great point, and I think it's an exciting area for future research. So if you're a TFH person, you know, I'd love for us to be in touch and think about ways we can work together. And then as far as the periodic nature of the disease, it's interesting because it's so periodic. I personally believe not because the natural history is periodic, but because we will knock it down with a drug and then it'll build itself back up, and it will knock it down another time with a drug. It feels to be more of a function of treatment and less of a function of a periodic nature, because it's not self-limiting. There are no patients we're aware of that have had a flare, that have had a self-limiting remission. But these are really great questions.
So thank you very much. I have to thank not only Dr. Fajgenbaum, but Dr. Abreu, who has been the master of ceremonies for this entire day. And wait, it's not over. Posters are coming this afternoon. Make sure you view them all, listen to them all. At the beginning of the talk, Maria showed us how to do all of that with her team. And then there's the award ceremonies with the virtual BYOB. And this is a day to truly celebrate, and what better way could we celebrate than hearing Dr. Fajgenbaum speak to us. So everybody, and also don't forget to sign the in for your CME, which is on the chat. So Dr. Abreu, we're going to see you later and have an opportunity to thank you for all you've done. Thanks again, Dr. Fajgenbaum, and we hope to see you soon in Miami. Stay well, everybody.
Thank you so much.